And we've been working with Qualcomm on this effort. Qualcomm has sponsored research at Palomar in an effort that's called Glassomics. And you can go to glassomics.com if you'd like more information about some of the R&D that we're doing. Don's going to demonstrate some of the glass apps that we're building for physician use. The first set of applications he's going to show you is a Watson-like capability, although not using Watson, but something that we're working on, which is to allow a physician user using glass to speak in symptoms and then go against the medical literature and provide in real time a differential diagnosis back to the glass user about what might be wrong with that patient. So he's going to go through and show you that first, and then I'll show you some other applications. So go ahead, Don.
And I'm going to try to put this in my ear.
Can't hear you. Okay, go ahead.
Okay. I may at times put the mic to my ear so that you will be able to hear what I'm hearing, hopefully. Okay, Glass. Start Isabel.
Isabel Assistant. Please tap to get started.
28-year-old female presents with photophobia and nausea and fever and neck pain.
Your request is displayed. Tap to process. Restate symptoms. Swipe forward to add symptoms.
Now, I don't know if you heard that, but it's giving me instructions that I can type to process, or I can restate the symptoms, or I can edit the symptoms. I'm just going to tap to process.
So we're going out to the literature, and we're going to present back a differential diagnosis based on those symptoms.
Multiple diagnoses found there. Intracranial hemorrhage.
So this is a very early example of what you can do with back-end technology and glass as an endpoint device, allowing the physician in real time during a consult with a patient to be provided some heads-up information. Now, we should recognize that 50% of physicians are below average, right? And so anything we can do to enable them to become better, to provide information back to them in real time is of great value. The next set of applications that we're working on involves the workflow in a hospital environment. The first set of apps deals with barcoding. Now, if you've been in any hospital environment, you know that medications are scanned, patients are scanned for identity. So we've built some prototype apps that do QR and barcode scanning using glass to identify a patient. And then you'll see that we're going against a real-time EHR system and providing laboratory results, medications, back to the glass user. And then finally, you'll see telemetry information. Real-time vital signs coming from a body-worn, sensor-based vital signs monitoring platform called Sotera Wireless. And we're providing real-time electrocardiogram information to the glass user. So go ahead, Don.
Okay, Glass. Start Glass Care. Good job. So this is how we would select a patient in this scenario. Sorry. So this is how we select the patient in this scenario, and then once we have the patient's information up, we have basic demographics, and then if we tap in the patient, now we have the telemetry information being pulled from a wireless device from a company called Sotera Wireless that we worked with to get real-time vitals information and EKG information. And then if we swipe, so now we have the EKG waveform that comes up. And like I said, on the screen, it's very crisp and smooth. There's a little lag between what we are able to display and what you see on the screen. And then one more time. And now here we're showing the lab values in the sort of the old school way, because we don't have that much space to present all the information. So we're using the fish bones to display the lab information. And then if we tap on that, we actually get the results graphed, and we can scroll through the results to see the different lab values. And we go back up and select another patient if we had to.
Okay. So just a glimpse in terms of some of the work we're doing in the glassomics incubator. Okay?
Great, thanks.
I think we end the panel now.
Right, yeah, I think,
That was cool. We just,
how do we follow that? I think
Yeah.
yeah, that was a great demo. Thanks for that. And so, because obviously we've seen glass for many applications outside of the hospital, but I think that was the first time I'd seen using things that we know about in the hospital, like Isabel, being applied through Google Glass. So I think my first question, and I'll take a few questions and then open it to the audience, is one that I'm personally very interested in. So I think 2 years ago, Vinod Khosla said 80% of what physicians do will be obviated in the next, by 2025. And obviously, as a med student, I called my parents right away and said, should I continue doing this or will I have a job? And that's the question I want to pose to you guys is, between things like Watson, advanced devices that are managing patients' care, and then things like Isabel on glass, where you may not need somebody who is trained for 4 years and incurred $200,000 of debt to be the front line. So can each of you comment on that? Will I have a job?
I think you'll have a job because even if you look at the enterprise, jump out of healthcare and go into business, that would imply that all the analytics we have about business is eliminating the need for a CEO. Right? At the end of the day, someone still has to make the decision to do something. And so I think although all these technologies are going to enable them, I think it's just going to change the way they work. But it's not going to eliminate the need for those kind of decisions to be made. And we have other industries to see that as an examples. They're just going to become a much higher trained, more technically integrated individual rather than just someone who writing on paper and still scribbling on notes. There's still going to be a lot of changes, but I don't think it eliminates.
One of the things that we're doing, and I don't know if I really emphasized that, if you looked at some of the data they were getting on glass, it was a lot of individual data points. What we provide is continuous information that's streaming in real time for the patient. So I think what will happen is you'll have access to data in real time for your patient, and historically be able to go back and look minute by minute, hour by hour, what happened to your patient. And what that will lead to is quicker interventions. You don't have to wait for the doctor to round or the nurse to call. You can have access to that data immediately and make earlier decisions on the patient, and that's where the real value is.
And I would go further than that, and I would say that you don't necessarily need to take interventions when they occur. You'll be able to have insight when events will occur before they do. So, for example, we developed something called the Data Baby in partnership with the University of Toronto Hospital, and it's the system is able to take streaming data about the baby's vitals in an EQ and be able to predict the onset of nosocomial infections. So as a doctor, you won't be rushing from bed to bed, or as a doctor within the hospital, but you'll be able to say, okay, we think that this patient may have an adverse event at this point, and so we can take proactive action to avoid that ever occurring. And so you'll be able to work smarter. You may work a little bit less. I mean, doctors are very, overworked within the hospital right now. So you'll be able to spend more time at the golf course, right? Or, studying or doing things you enjoy. Yeah.
Great.
Yeah, I think Vinod has corrected himself somewhat since those statements. But definitely what we demonstrated here is really the ability to provide additional information to the doc in real time. And it's in no way ever going to, in my opinion, replace a doc, right? I mean, this is kind of crazy. But we're going to see, and I like your comments about continuous monitoring. Because today a large percentage of patients in the hospital environment are spot check monitors. Right. You come in every hour, you wake the patient up, you take their vitals. We're getting away from that. At our hospital, we don't have that at all. We've replaced it with continuous monitoring. All that information with analytics is going to provide a heads up to the doc. So we're just moving in that direction right now in terms of enabling the physician to really get all the information they need in real time. Yeah, so we could go down a different thread in terms of implantable devices and other sort of things that we're doing some research on that really is something that docs are going to be very interested in.
I think one of the interesting things that we'll see with the upcoming generation of doctors that grew up in a more technically integrated world, that we're going to see more doctors that are becoming entrepreneurs, I think.
Right.
Because they will understand how technology works in a different way. They will want to improve the way that they care for their patients, and we'll see a change. And there's enabling technologies that make it easier for them to do that than it was in the past. You didn't have to be a computer science. You don't have to be a computer science major to have a tech company anymore.
Right.
I think they'll demand change.
Yeah.
Right.
The younger kids won't put up with some of the ways it's done.
Yeah. they won't.
Yeah.
Actually, that's a follow-up question I would have. I know, Orlando, you can probably comment best on this right now, given that you're at Palomar. Just a quick follow-up to the role of the clinician, how it's changing. Do you guys interview your physicians before you hire them and make sure they know how to use, say, an iPad?
Well, I've been in this business long enough back at the University of Michigan where we attempted to implement computerized physician order entry back in the 80s when doctors wouldn't touch it. All right, so multi-million-dollar investment and physicians refusing to use a computer to do orders, okay? We're not at that point, right? So fortunately, everybody's computer savvy, and we don't see those barriers anymore. I mean, that is just not a barrier to entry. All the docs coming out of med school are doing CPOE, they're doing electronic medical record utilization, very comfortable with doing e-prescribing. So we just don't see that.
Great. I guess another question I would have is, so technology obviously at CES is, most people would say it's not a panacea even here, even despite the fact that everyone loves technology and that's why we're here. I write for a blog called MedGadget. And so one problem I see with technology in hospitals is that it tends to raise costs and it tends to be implemented too quickly. Some hospitals seem to implement technology more as a marketing tool rather than as a actual evidence-based, for evidence-based reasons. So with the technologies you guys are describing, how do you avoid becoming a marketing tool and instead being purely evidence-based and actually improving outcomes?
We actually do that. Some of our technologies will go in and are the same cost or reduced cost. In fact, we'll come in and say, if used in this proper way, it could save you money.
Right.
So why wouldn't you make the change? And that's really some of the discussions that we have. We believe that we can save, I think our CEO said, so I'm safe to say this, $4 to $5 billion if our technology was fully implemented throughout the United States, for example, with all of its different bells and whistles and caveats and things that would warn the clinician so that they maybe wouldn't give blood, for example, or they wouldn't wait so long in the patient's deterioration, and they'd be alerted earlier that there's a problem and intervene much earlier. We think that's the savings. When I first trained 30 years ago, when we would round in the morning, we would find dead in bed, people that had expired during the night, or people that were on the last leg, and we would try to resuscitate. Many times they would die. Well, then we've moved to rapid response teams in the hospital now, so that people can call a code earlier. Well, the end result of that is they end up in the ICU, and that's the most expensive place to be. Yeah, they don't die, but now they incur enormous costs, and maybe they still do die. The idea now with reliable technology that doesn't false alarm is you have maybe predictive capabilities, or you intervene so early in the process that they stay right in the room they're in and they go home in a normal fashion or in an earlier fashion than they would have otherwise. So we believe all of those factors can save hospitals enormous amounts of money.
The idea of value is a critical issue in adoption of any technology, making it radically simple for the provider, the clinician, as well as for the patient. But then, of course, the economic value. I mean, there have been a number of pilots done around telehealth or mHealth that address the point of cost avoidance. So if a CHF patient is discharged and has an adverse event while at home, during home care, the ability to get insight into that before it happens, is very limited at this point because the system is so disconnected. But having a Massimo device in the home, streaming data back to the nurse's station in the hospital, and they're able to monitor it, or giving alerts to say, something funny is happening, you need to take action, you need to send an ambulance, or call the patient or something like that, will be absolutely critical. And so being able to move the patients out quickly to their home, to improving their quality of life, while still being able to have insight into what's happening, I think is essential. And you'll have, I think we've estimated that, about $17 billion of cost can be avoided by the reduction of 30-day readmissions, for example. So tremendous value can be achieved.
I think too, there, in the past, the technical organizations within the healthcare facilities were operating under old paradigms, and those old paradigms have high costs. They do. Cloud computing, big data analytics, the technology enablement now that exists, where it used to be you kind of had to do these things from scratch, you kind of had to build them on your own, but now there's a lot more opportunities for shared resources. The hospitals now can say, look, technical organization, can you go do this for me? And they can actually come back with a lower cost alternative to get it. When you can do a lower cost alternative, it becomes easy to do it at scale. And that's really the challenge in the past. A lot of times they did a marketing thing because when they looked at it to do it at scale, the cost was just through the roof because they were operating under the old model. The new model allows them to technically deliver at a much lower cost, and that's enabling these new technologies to start to make their way in.
Right.
There is a challenge in terms of adoption of emerging technology in healthcare. Let's face it, 95% of hospital organizations are basically non-innovative. Very late adopters, followers. I would say there's only about 5% of healthcare organizations in the US that are true innovators, that proactively meet with startup companies, that bring startups in. They have a sandbox environment where you can innovate. They actually do their own invention. So that's been a big challenge. We're seeing a lot of investment in innovative startups, but they can't gain traction in the healthcare systems because there's just a handful that they can deal with,
We've experienced that firsthand.
right?
We've
You've got
experienced that
very
firsthand, absolutely,
innovative
yes.
technology, but penetrating the market,
They're not
is-
lining up to buy sometimes. You have to go through, because many of them are late adopters now.
Yeah.
they're all late adopters.
We're
It's
actually
like-
creating these support structures for them to baby step into innovation. We really are. It's kind of an interesting thing to watch. It's like, here, we'll do this for you, and you can dabble in this and dabble in that, and get comfortable with it, and then move to the next phase. And it's,
Yeah. They have a history of failing late and large,
yeah.
right? So $300 million EHR project, 8 years later it gets canceled. They don't understand the principle of failing early and small, and don't have an environment for taking some of the new stuff that's coming out of your lab, for example, and testing it before they actually go and launch it, right? Pilots and all that stuff. So yeah, you really got to help them in terms of gaining traction for that stuff.
So
And I think
go ahead.
a key characteristic or a key term you used was within the U.S. So
Yes.
one thing that we've discussed with our clients, and I think there were some gentlemen from Taiwan, is that you should look for opportunities around the globe. Engage with ministries of health in areas like Singapore and Taiwan and the UK, because they may have more proactive thinking, and the governance model may be that they can take a leadership role and help to drive that technology.
That's-
We're already doing stuff around remote monitoring of diabetes and heart disease in Taiwan with some of the hospitals there.
Well, sometimes, I used to run the healthcare vertical globally for Sun Microsystems. And when I would look around at other countries, we did the national health card for South Korea, right? Smart chip, Java card, all those innovations. To try to do any of that in the US, given our fragmented system, it's impossible.
Yes.
So sometimes a benevolent dictatorship gets things done a little more easily, especially for a vendor like IBM.
Well,
So
that's kind of one of the things we've been able to do is consolidate a lot of those solutions in a single ecosystem so you can avoid the benevolent dictator. Not that there's anything wrong with benevolent dictators, but you can avoid that and still have that independence to be able to execute on that area.
Yep.
So.
I'm afraid to cut you guys off here. We have just under 5 minutes. So I want to make sure that the audience has time for at least one or two questions. If anyone has a question out there, go ahead. Get a mic. I think we could talk for hours about this. Obviously, it seems to be the theme for every panel.
Thank you. I wanted to know if you could pinpoint, I know every institution is different, but if you could pinpoint one decision maker at an institution that we can focus on to get technology and solutions into a hospital network. Is it
Chief
CMO, CMIO?
Chief medical or chief nursing officer. If they were driving hard, that you can get the technologies in.
This is the question I get asked from startups, right? Unfortunately, Yeah, you've got to go that way because you really don't have innovation officers.
Right.
I mean, I think you can count on one hand the number of innovation officers among healthcare organizations in the U.S.
Risk officers, though, might be a call point.
Risk?
If someone that's looking
Well,
at
they're
risk
usually
overall.
risk avoidance, right?
Right,
They're not
exactly.
like, so they really struggle with, I've got some cool new thing.
Yeah.
And I'm looking for somebody to work with to see whether this new idea can translate into the real world practice of medicine. It's not productized, it's conceptual. And I need somebody to collaborate with. How do I do that? It's that same list of healthcare systems that everybody deals with. How do you get healthcare executives, this is the challenge, to become much more innovative through education and all of that is a big challenge that we're going to have
You
to
show
confront.
them in their current practice, they're at risk, and they
They're
want to
at- yeah.
reduce their risk.
Yeah.
Is my point.
Yeah, there's got to be like an ROI. and you run them
Exactly.
through- handhold them through that process.
We beat the technical teams over the head with a big bat until they succumb and agree. No.
That always works.
Yeah, that's
Well,
just kidding.
We often engage with the chief medical informatics officer to serve as the internal champion for new technologies within the hospital.
So time for maybe one, maybe two more questions. Anyone else has a question?
So this question was for Mr. Portale. I'm sorry for mispronouncing your name. I really like what you're doing with Google Glass, but does changing or creating applications like that on Google Glass, does that change the device from a consumer electronics device to a medically regulated device? Have you entertained talking with the FDA to understand if
No.
they're thinking of that as a regulated device?
Yeah, no, I don't think the endpoint device would be regulated in this use case. Okay, so for example, I could use a Dell desktop computer to view vital signs. The software application is what's going to be regulated, and you'll need to do a 510K on the software apps. I don't see them going after the glasses and endpoint device to have that become regulated. Is that?
I would say it only changes if the data starts to leave the environment, right? As long as you're walking in a closed loop system, it's probably, but I think if the data starts to leave the environment, then you could have some issues.
If Massimo wanted to bundle up a glass solution tightly tied to your body worn system, you're going to do a 510 and include glass in the filing. But Google won't have to do that, right? It's just it's your own sort of thing to deal with.
Great. One quick question left. We have about a minute.
This is Kurt from Linkstar Technology. My question is there a medical hospital or community so people can visit and try to taste it? Maybe in Taiwan or somewhere else?
Is there a hospital that practices the radical concept?
So a good example is if you go to, you do a Google search on Bloomberg, Palomar. So Bloomberg has a show called Brink, and they came out to Palomar and visited this $1 billion new hospital that we just opened. And it includes not only a radical change in terms of the architecture associated with a hospital, but then all of the technologies and the infrastructure that went in there is very radically different than you're going to see in most hospitals around the world. And they did a piece, and you can go on YouTube or the Bloomberg site and see the piece they did about what we did. And I think it's a good exemplar to see how far you can push the boundaries right now.
Great. Well, we're out of time, so I'd like to thank our panelists once again.
Yes, thank
And
you.
Thank you.
Thank you, everyone.